last presentation this afternoon is on mitigating ligature risk and other patient self-harm risks. I've been asked to make sure everyone's aware that this is on, I guess, the Joint Commission short list for things that they are looking into in your institutions. Our speaker this afternoon is Deborah McGuire. She has a bachelor's and master's degree in nursing from South Alabama. Spent a fair amount of time at St. Vincent's and is currently the executive director for psychiatry at Brookwood Baptist. Is going to share with you what their institution is doing. So please help me welcome Deborah.
Good afternoon, everybody, and I want to thank everybody for staying around. We're going to try to get you out of here on time, but I will stay later and answer any questions if anyone has any specific questions that we may not get a chance to get to. So what I would like to share with you briefly today is identifying ligature risk and mitigation strategies for your organizations. Again, we're going to talk about the Joint Commission because that's the accredited organization that we try to follow, but also for those hospitals that are not Joint Commission accredited, there's some requirements for you as well. So I want you to pay close attention to what we've done and what we've seen throughout our market. Within our market of Brookwood Baptist Health, we have 5 hospitals within our system in the Birmingham or in the Alabama area. And all 5 of our hospitals have behavioral health units. So I will take you through a journey over the last year and a half of what we've done to increase focus on litigation risk and mitigation strategies, because that's what the Joint Commission did starting last year in 2017. So at the end of this presentation, I want you to be able to verbalize the scope of suicide in acute care inpatient settings. I define what constitutes a ligature risk as defined by CMS. Identify frequently missed ligature hazards. Sometimes we will identify the obvious, but some of the more obscure risks we will miss. You will also be able to identify strategies for developing an effective risk assessment and mitigation plan. So in 2007, Joint Commission came out with National Patient Safety Goal number 15. It increased focus on preventative efforts for patients that are at risk of suicide. But what Joint Commission has said is that 21% of hospitals that have behavioral health units or behavioral health hospitals that are accredited by them were out of compliance with that requirement. It's been 11 years, 2007, and we still have that level of non-compliance. And what they're saying is 5% of accredited hospitals that may not have behavioral health are out of compliance. You don't have a behavioral health unit, you're out of, but you still have an emergency department, so you have to be in compliance with National Patient Safety Goal 15 because you got to identify those people who are at risk. So the organization has to define that. So there are 3 elements to National Patient Safety Goal number 15. And some organizations do very well with the element of performance for all 3. Some hit or miss, 1 or 2. But I want you to know that, it's in the forefront of what Joint Commission is doing now is looking at behavioral health, non-behavioral health areas, risk assessments, and then the corrective action and mitigation strategies. So the first thing is that your organization has to conduct a risk assessment. The second element of performance is address the immediate safety needs of that patient and make sure that that patient is in the most appropriate setting. That is very important whether you have a behavioral health unit or not. The patient has to be in the most appropriate setting based on an assessment that you've done. And then the third element of performance is that you have to provide the patient who's at risk, you have to provide them information and resources at discharge. You have to include that in their discharge instructions. And we'll get to how we're going to do that in just a minute. So just a little bit on statistics so you will see how important it is that we identify these patients that are at risk. In 2014, it was reported that there were 383,000 ED visits for self-inflicted injuries. And this information came from the CDC's website. Almost 400,000 ED visits for self-inflicted injuries. Suicide currently is listed by the CDC as the 10th leading cause of death. So it is almost at epidemic status. It's the 4th reported sentinel event to the Joint Commission. From 2010 to 2014, 1,100 patients committed suicide on an inpatient unit. 5 to 6.5% suicides were committed inpatient, but Joint Commission, they believe that number is underreported and is actually higher. The most common means I put a / medical versus psych, being medical being on a medical floor, and then the psych, of course, being in an inpatient psych unit. The most common means for inpatient suicide in an acute care setting is on the medical floor is jumping. On the psych floor, that's going to be 28%, on the medical floor 53%, and hanging on the medical floor 16% and 22% on the psychiatric floor. So last year, when one of our hospitals in the metropolitan Birmingham area had their Intercycle Joint Commission survey, I asked one of the surveyors that I had an opportunity to talk with, why all of a sudden is all of this focus? Why has Joint Commission just all of a sudden, since 2007, decided 10 years later, we're going to focus on it, focus on it, focus on it? And she told me to go and Google this case, the Montefiore case. And so in your spare time, you can Google it, but the Reader's Digest version of that is there's a hospital in New York named Montefiore, and within 8 days, they had 2 inpatient suicides on a geriatric psych unit. And after that, CMS gave them the directive, you need to ratchet up what you're doing. You need to be a little bit tougher with what you're doing because this should not happen. What she did share with me that day was that when they went back, when Joint Commission went in, this hospital had done a very good job of doing a risk assessment. They had done a very good job of putting policies in place, but no one checked. No one checked to see if the staff was doing what the policies say they were going to do. No one checked to see if it was done consistently. It was not part of their performance improvement program or anything like that. They just annually did the risk assessment, made sure the staff had the training update annually, and that was it to the next time. So guess what? Now Joint Commission is looking for more than that. So contributing factors. What happens when there's a lapse or a decrease or something happens? You can go back to see there is something that's contributing to the holes or gaps that we see. Number 1, assessment. What type of assessment are you doing for the patients? Are the assessments inadequate? Are they incomplete? Or they're not evidence-based? I can tell you for our organizations, Joint Commission has harped on evidence-based suicide risk assessments. They don't care which one you use, they asked you. We recently had a Joint Commission survey a month and a half ago, and when talking with the surveyor, he says, who's the author of this suicide risk assessment? Is it evidence-based, and where's the proof? So you've got to make sure, look at your tool that you're using to screen or assess patients for suicide. Make sure it's evidence-based. Make sure that staff has the appropriate training. Make sure that they know that if it has a blank there, the blank needs to be filled in. Don't leave blanks on assessments. Also, they're looking at closely staff communication and handoff. When they give shift report, is that patient's level of observation or the patient's suicidality, is it communicated? What happens when the patient goes to another department? How's that communicated if the patient is going for tests? How is that handoff done from shift to shift? If something happens on one shift that increases that patient risk, is that handed off to the next shift so that the patient can be adequately observed or make sure that they have the proper observation level? Safety rounds and observation levels. Make sure that it's based on assessments. If a patient comes into the emergency department and the patient is moderate or high risk, what did you do for that? What does your policy say you would do for that? And so we've had opportunities that we've seen where the patients were moderate or high risk, but the policy was not followed consistently. Or we've seen where the patient was moderate and high risk in the emergency department, and when they get to the medical of the behavioral health unit or to the ICU, that particular person that's assessing changed them from moderate or high, but based on their assessment, the patient is now lower. But we got to make sure that really, again, if it's an evidence-based tool, the results shouldn't change that drastically going from emergency department to the behavioral health unit. What happened in that transition from one department or another that they were high risk and now they're low risk? We've got to make sure that our tool is a valid tool. And then lack of staff education. Does your staff know what the hospital's policy or your organizational policy is on suicide risk and prevention? Does your organization have a policy on suicide prevention? Has the policy been reviewed and updated? And then environmental safety. What does your organization do to ensure that individuals that are high risk for self-harm, that you're maintaining them in a safe environment? It does not matter that they're in an ED or an ICU. Joint Commission and CMS realizes that you're not going to be as vigorous as an inpatient behavioral health unit, but you still have to keep those patients safe. And then sometimes contributing factors with that 21% and that 5% non-compliance is the environmental risk assessment not conducted at all. So that's one of the first things that we've seen in our organization when Joint Commission comes, when they get ready to assess the behavioral health area and the emergency department, they're asking for the risk assessment. And they want a working document where we've corrected things and we have a plan for getting things completely corrected. And we also have a plan to mitigate those things that we can't correct. So consequences, what happens if you don't have an environmental, a risk assessment, or you don't have policies and procedures, you don't have an evidence-based tool to assess the patients? Well, number one, the at-risk patients are not consistently identified. Some patients will drop through the cracks. Proper safety precautions may not be initiated because we don't have the proper tools or we have not used the evidence-based tool. You will have increased incidents of patients that are actually harming themselves either in your organization, or they'll go home and harm themselves back in the community or back at home. You'll have increased oversight, regulatory oversight, and I know we all don't want that. Even though it's a good experience, it's not an experience that we like to live every month. So increased regulatory oversight, but if you have these sentinel events, you're going to have visits from CMS, you're going to have visits from Joint Commission, you're going to have visits from the Alabama Department of Public Health, the news media, and everybody else. So you have increased regulatory visits and oversight if you have holes in your product. And then, of course, last but not least, increased litigation. You can't watch TV without seeing an attorney on TV saying, call me, call me, call me. So I think because we do live in a society that's more litigious than it used to be, you're going to see that patients will call the attorney before they call the doctor or something like that. So then we end up, as a consequence of all of that, being in a whirlwind, spinning tornado, not knowing what to do. So you ask, where do we start? So you got to first start with defining what a ligature is. And this is CMS's definition of ligature. Anything that can be used to attach a cord, rope, or other material for the purpose of hanging or strangulation. So that could be anything. So know your risk. For the patients, you got to have evidence-based risk assessments. You need a patient screening and assessment tool that all staff can utilize and take action based on the risk. It's not okay just to assess the patient and identify them at risk, but then based on what you've identified, what are you going to do? And the bottom line is we have to keep the patient safe. For your environment, you need to do an environmental risk assessment. Your emergency department, your ICU areas and some of the larger hospitals have multiple ICUs. It's where you admit your behavioral health patients. And then, of course, your behavioral health unit. And then corrective action. It used to be, back when they first came out with this in 2007, Joint Commission would allow you every year just to do the risk assessment, and then you mitigate everything. You don't correct anything. Well, now they're saying you have to correct. You just can't mitigate everything. So if you identified something in 2010, it needs to come off that list every year. You can't just mitigate. You've got to correct, and you have to. And they understand that it costs millions and millions of dollars, but you have to have a plan in place to show that you're working toward correcting and not just mitigating everything. So you want your risk assessment each year to be less and less correction because you've cleaned it up. And then mitigation is things that you can't correct. What are you going to do? What are you going to put in place to still keep the patient safe? So some obvious risk factors that we see in our environment are, door handles, door frames, windows, coat hooks, we can see the obvious things that we can hang ourselves from, or the patients could hang themselves from. But some of the more non-obvious things that we see is who thinks about the vents and the grills and the light fixtures. While we were sitting here waiting as the day went on, I started looking in the room and I was like, okay, these are drop-in ceiling tiles. There's projectors there, the diffusers in the ceiling, all of those. If this was a inpatient psych area or this was an emergency department, we have a lot of things, the chandeliers, the light fixtures, the mirror on the wall, all of those things that you may not think about on a regular basis, are all things that we need to think about in our organization that a patient could hurt themselves or harm themselves with. So much so that even at one of our hospitals, we have a piano that's in one of the patient day rooms. We've had the piano bolted to the floor. We've had casings put around it so they can't wrap anything around it to get some kind of trigger point or a pinch point that they could put anything over it. We've gone that extensive to try to make sure that the environment was as ligature resistant as it could possibly be. You wouldn't think about paper towel holders or soap dispensers, but those things, if they have a flat top, they could actually hook something on it and it becomes a ligature at that point, including furniture, tables with legs, chairs with legs. We want to make sure that we look at all of those things when you're doing an environmental risk assessment. So patients taking action, we want to make sure for our patient risk that you have policies and procedures developed to address assessments, precautions, and preventions. And making sure that all staff know what type of tool you use, how often are you going to use it, what do they do if the patient triggers at high risk, and then what kind of precautions does your organization use? Do you use constant observation? Do you use line of sight? Do you use one-to-one? Exactly define what your organization's precautions are, and then what are you going to do to prevent the patient from hurting themselves? Staff training at a minimum upon hire and annually, and anytime there's an incident, if you have a sentinel event, that's the time for staff retraining, because somebody missed a mark or somebody was absent the day of class or somebody forgot about something. And then monitor staff for compliance. Usually when I go around to our hospitals, I will usually ask if they have someone that's on constant observation because they were high risk to hurt themselves. If they say yes, I'm going to talk to staff to make sure that they can talk about the policy. They can tell me what the do's and don'ts are of observing that patient. What's the level of observation? Are they in compliance with that? The documentation, what does the documentation look like? Are they documenting according to our policy? And then I'm going to come back and look at that patient's plan of care to make sure in the care plan or the treatment plan, all of that is documented to reflect that the patient is on whatever level of observation, constant observation, one-to-one, what does that mean for our organization, and can staff speak to that, and is it in the plan of care? And is it documented every day to justify, are the patient's behaviors documented to justify that level of observation? And then also we have, for our behavioral health units, we have a solid handoff process where we talk about the patient's level of observation every day, what behaviors they're having to warrant that level of observation, and if the patient for that previous shift, did they have those behaviors, and can we step them down? You know, we don't step down except for with a physician's order, and that's why part of rounding with the physician and treatment team makes it imperative that all players that are on the team participate in that. We can talk about that patient and their behaviors and what happened, and you know, are they ready to come off that level of observation, or do we need to continue because they made a gesture? And all of that is documented, and we try to document every shift the significant behaviors that keep that patient, that puts that patient at risk, that would warrant them being at that level of observation. And then also with the plan of care, we try to get the family involved with the patient's permission as much as possible, because when we go home, when the patient goes home, we have to partner with them to keep that patient safe as well, because we want to focus on discharge planning and keeping them safe. So someone would need to be there to manage their medication, make sure household poisons and chemicals are managed and put away, and also managing guns, their access to guns and ammunition. So we need to partner with families, but that also needs to be documented as well, because sometimes we can do all of that and do it very well and still have a negative outcome. But if we can show that we did everything possible that we could have done, then the situation, if you have regulators or other entities coming in, they could see that we did everything that we possibly could to keep that patient safe. And like someone said earlier today, you know, if we don't document, then it never occurred. We may have done it, but just didn't document it, then we don't get credit for that. So taking action for your environment, you want to make sure you have your annual risk assessments, corrective action, mitigation strategies, environmental safety checks daily. Usually when I visit my hospitals, I will take one of the mental health techs. I said, come make rounds with me, and we do an environmental safety check and see what I come up with, because they should have, before I come along, they should have done their own environmental safety check. So I shouldn't be finding clothing with drawstrings. I shouldn't be finding belts or shoelaces. I shouldn't be finding a lot of toiletries that have warning labels for ingestion, because guess what? Somebody could collect all of those things and they could ingest it. Patients do. Is there excess linen in the rooms? We look for all of those things. So usually, because the mental health techs are the ones that are right there close with the patients at the bedside, I usually would take them with me, and that's a learning opportunity for them. And so when they're training other mental health techs, they would teach them how to make sure that the environment is safe. Also, EOC rounding. We have EOC committees at a lot of our hospitals, and they round. So these are individuals that don't work in behavioral health. So they will make rounds. They have a checklist that they go by. So it's a new set of eyes that will come and round on our units. And then a lot of our things that we are mitigating, some of the things that we're mitigating, we have to put on a preventive maintenance schedule. Like we have some lay-in ceiling tiles at some of our hospitals. So the ceiling tiles are clipped, but unless somebody checks it routinely, somebody may have gone in the ceiling to do some work and left it unclipped. So we have our ceiling tiles on a preventive maintenance schedule, so that monthly somebody from Plant Ops would come and check the ceiling tiles to make sure that they're still clipped. So mitigation strategies for behavioral health, we want to make sure, again, the evidence-based screening tool and assessment, ensure proper observation level and rounding based on that assessment, environmental safety checks every shift, ligature-free. Yesterday, I think Joint Commission changed ligature-free now to ligature-resistant with guidance from CMS. So Ligature resistant is a must in patient rooms, bathrooms, corridors, and common areas. Staff supervision in common areas, we have to make sure that patients are not left unattended. Consistently follow our policies and procedure. Frequent reassessment of the patient's risk, making sure that we don't assess them in the beginning and then forget about them. We assess our patients every shift, and then we assess them again prior to discharge for their suicide risk. Staff training and competency, treatment plan. I cannot say this enough. We got to make sure that our treatment plan captures the discharge plan, follow-up referrals, initiating crisis plans, and family involvement. All of those things need to be addressed in the patient's treatment plan. Solid handoff process, and then a risk assessment for identified risks that can't be corrected. So one of the things that we have done at Brookwood Baptist Health, our parent company is Tenet Healthcare. We went throughout our organization to the psych-safe medical beds for our geriatric unit, and then some of our adult units also have a few of those medical beds that are deemed psych-safe. You can look in the 2018 design guide and you'll see a picture of them right there. And we had Joint Commission about 2 months ago at a hospital, and we had the life safety officer from I don't know where. And he hated the bed. Even though it was in the design guide as being a psych-safe bed, he pulled a mattress up and he's like, this is a death trap. So guess what? We went back and we had to do a risk assessment because we spent hundreds of thousands of dollars on those beds. And so we're not gonna replace, they're in the design guide. It's the best practice for psych at this present time. So what we did, we went back because it's cost prohibitive to change, and there's nothing out there better than what's already being recommended. So we're doing risk assessments for the beds to show that we haven't had any incidents related to the beds. You know, if we had someone that was high risk and they needed to be in that bed, we have a policy that say they would be a one-to-one and all of those things. So we were able to show that mitigation strategy, and that satisfied them. So again, they're very detailed in what they're looking for. So strategies for non-behavioral health areas. In the ED and the ICUs, you want to screen all patients. Make sure that if you screen a patient and it's triggered, they get a full assessment for that risk. Constant observation for patients that are with increased risk. Creation of a safe room. In all of our hospitals in the ED, at least one room has been designated where they tend to place most of the psychiatric patients. And then they have so if they admit a patient to that room that have behavioral health needs, they have a checklist that they will go in to remove as many things as possible that they can remove so that patient will be safe. And then there's a risk assessment, again, that's done. Like in the ED, some of the overhead lighting, even though it may be a risk assessment or provide an increased risk, they can't remove those lights, so they would do a risk assessment. And based on that patient's assessed need, if need be, they'll have a one-to-one for that patient. We've also developed protocols for visitation. I know a lot of ICUs have open visitation, but what we're doing is we're going by the visitation for the behavioral health units. We're not doing, because we've seen in a couple of hospitals where family members have brought in contraband to the patient, so we really supervise the visitation and don't really have open visitation for the behavioral health patients. And then staff accompanies our patient. If we have a patient to go, they have to go somewhere for tests or procedures, behavioral health staff member or ED or ICU staff member will accompany them. And again, a solid handoff, so everybody knows who the patient is, what their risks are, and what we're doing to prevent those risks. Joint Commission focus that we've seen in the last year and a half is they will review your environmental risk assessment and evaluate the process. Do you have a good product? And then they will evaluate the extent to where you've tried to correct things. They do realize, again, that this is cost effective. They just jumped right on it with no warning fix it, fix it, fix it. But they want to make sure that we're not stuck in a holding pattern with correcting things. So you have to have a plan to correct. And then they also thoroughly looked at our policies and procedures for suicide risk, observation level, and rounding. And they watched to make sure that if we said the RNs were rounding every hour or every 2 hours, someone was there doing paperwork and waiting for the nurse to come around every hour or every 2 hours. Because then, you know, if we did not, they would get us for not following our own policy. And then staff level of competency. They talked to the staff, the frontline staff, the staff sitting one-to-one. Could the staff speak to the policy? Or did they struggle? Could the staff talk about the training that they've had? Could the staff tell them the do's and don'ts, the what, whens, and hows and whys of managing patients that are at risk? Potential outcomes, immediate threat to life, we commonly known as the immediate jeopardy. You do not want to get that. That is at the top of the SAFER matrix, the survey analysis for evaluating risk. Or you could get a conditional finding. Either one, you're going to get a revisit from the Joint Commission. Life safety waivers are not applicable when Joint Commission cite in this area because it's not life safety tags or life safety regulations. But they do have a program or a plan that if you need additional time to get your environment more ligature resistant, you can work with whoever your account executive to help you get more information or enroll in that plan if you have not, if you need more than 60 days to get your organization into compliance. And then there's more guidance to come. They still have not worked all this out because CMS finally realized that they kind of went at this full speed. And not every hospital had hundreds of thousands of dollars in reserve that they can just donate or put to this project. So they've kind of slowed down a little bit, but they're still coming. So I would not hesitate to get the program up and running. If they see it, they're going to cite it. So from a quality management standpoint, you should monitor patient safety events and incidents when applicable and appropriate, do root cause analysis, review and revise your policies and procedures annually and as needed. So if you have an event 6 months after you reviewed your policy, you may want to look at the policy again to see if there are any gaps. And then also, you're going to review and revise your risk assessments. Our risk assessments are a working document until we get completely ligature resistant in all of our organizations. We work on it weekly, monthly. As things are corrected, it changes and it looks different. So your risk assessment should not look the same from January to January. There should be some degree of work that's being done that you can show your progress as you're going along. So it takes all of us as a team to make this successful. You know, if the middle wheel is not trying to do the front wheel, the blue wheel is not trying to do the yellow, so everybody has their job, and it's all of us, it takes all of us as part of a team to make this very successful. And so I see some faces, and this looks kind of maybe confusing to you, so I want to leave you with a final picture of what a successful team looks like.
Anybody have any questions? I've got lots of questions I can't get into right now, unfortunately, so we'll have to do it for another day. 2 minutes. Let me just quickly thank all of our speakers, thank all of our sponsors. I appreciate, we certainly appreciate the sponsorship, and I want to thank Rosemary and Margaret. Can they put on a party or what? Thank y'all for that. Quickly get your CEU business done, your continuing education stuff done. There's going to be an email survey, so please let us know what you think about the site and the program today. And let me say finally, you're all top performers for what you do for your organizations and for your patients. We are very grateful. Thank you. Travel safely.